So what I'm going to do is just talk very quickly about our experience in the treatment of radial club hand. And the first thing is that this is the first cohort of patients that we treated with distraction, preoperative soft tissue distraction. And to actually make some comments that are worthwhile, you actually need large numbers. And if, for example, let's say that was 200 cases over 20 years, say an average of 10 cases a year, and you had to wait for skeletal maturity before assessing your results, at the end of that 20 years, you'd only have 4 years of complete follow-up. In other words, only 40 cases. And you really can't comment on whether the results are good until then. You can tell if they're bad because that becomes obvious much earlier. So if you look at the literature, many of the series are small. The follow-up is often short. There are often missing technical details so that you can't really compare different series. There are even different definitions. And many of the so-called radializations actually have carpal slots, so they are in fact centralizations. And very often they are centralizations where the ulna has been placed opposite the second metacarpal, rather than the third metacarpal, which is the central axis of the hand. Now, George Murphy did a nice review and analyzed all these, and it was amazing that the number of series that had reasonable follow-up was really quite small. So prior to 1995, at Great Ormond Street, we used standard centralization with the ulna opposite the third metacarpal, plus tendon transfers. And from 1995, we started to use soft tissue distraction with the idea of proceeding to radialization so that you could get good wrist motion and that you could preserve ulnar growth and preserve forearm length. And I'm really going to talk about type 3 and type 4 only. To my mind, type 1 and type 2 are completely different animals because they have a radiocarpal joint. Not only that, type 2, of course, the radiocarpal joint is abnormal, but they still have a radiocarpal joint. And these two types are also, in my mind, stable and non-progressive. Type 3 and 4 are completely different. They really just have an ulnar carpal pseudarthrosis. There is no wrist joint at all. And that brings me to a point when people compare in the literature preoperative wrist motion with postoperative wrist motion. I mean, this is nonsense because it's just a floating pseudarthrosis that we're talking about. So when we started to do the distraction, we have done, well, we've done over that now, but at that stage we had done 101 with preoperative soft tissue distraction. And prior to that, we had 33 cases where we had just proceeded to immediate centralization with tendon transfer. And we thought it would be useful to compare the two. Now, just a couple of comments that, that we need to make. The fibrotic anlager in type 3 can often be a problem. The other thing that can be a problem is that if you look at the shape of the ulnar head, it is often biplanar. It's like the roof of a house. And sometimes that can cause problems if you don't deal with it. When we look at the type 4, again, we have the problem of ulnar curvature, and the orientation of the distal ulnar head again can be a problem. Nothing particular to say about the soft tissue distraction, except perhaps to say that 80% of the distraction that occurs actually occurs when you apply the distractor. And when you read about how carefully you must slowly distract the distractor, it's really talking about the post-operative distraction. We didn't have to do, I think we only did one bony osteotomy in that series because, of course, the bone remodels, but it doesn't solve the problem of the distal ulnar epiphysis. Second stage, we take off the distractor, just use a linear incision, it gives you the best exposure. We don't need to worry about the soft tissue excess. And that excess is actually caused by a little fibrotic band which runs from the depth of that dimple to the base of the ulnar styloid. And if you divide that, that dimple disappears and the ulnar tissue excess disappears. Really important to divide the combined radial muscle mass. These radial and dorsal volar muscles are all condensed into one muscle mass. And it's inserted into the base of the second metacarpal. It really has to be divided and transferred. And we like to transfer it across to the ulnar side of the carpus rather than extensor carpi ulnaris. The other thing is, of course, we've got to divide the deep fascia from the mid-volar point to the mid-dorsal point. And once you've done that and you've divided the radial muscle mass, we can rebalance it and change it from an internal deforming force into a corrective force. And we also shorten ECU. So were we able to achieve our aim and radialize in most of these cases? Well, we found that we could, in the first 32, that we could radialize in 26, but 6 we couldn't and had to centralize. But actually, of that 26, 10 of them we had to reoperate for angulation. And we took a marker of a 25-degree recurrence as being an indication to reoperate because it was only going to get worse. And so we felt operate early and solve the problem. So at about 36 months, it wound up that we had 2 groups, one which had primary radialization and another group which had been centralized either primarily or secondarily. The 2 groups were pretty similar. If we looked at the makeup of the 2 groups, their syndromic associations were very similar. But the thing that was different between these groups on analysis was that the centralized group, which had not been distracted, and the distracted group, and then followed by a wrist procedure, either centralization or radialization, there was a significant difference in ulnar growth and therefore in forearm length. And if we plot this and look at the percentage growth, I'm sorry, there's a computer glitch here which has put the lines in inappropriate places. But if you look at the green dots, you can see that green line should be further up. And if you look at the purple dots, the purple dot should be more like where the green line is. I think the computer's gone mad. But clearly there was a difference. And it may be that distraction is imparting a protective effect on growth, certainly over the first 5 years. But what about the long-term results? Does it last? So we followed these to skeletal maturity, and I'm just going to skip through this. Obviously, we looked at the X-ray measurements, and we also did some clinical assessments as well. And the interesting thing that we found was, of course, as you'd expect, the range of motion was best in those that had been radialized, far better than those that had been centralized, and it was worst of all in those who had had failed radialization followed by centralization. But interestingly, the power grip was best in that group. Now, when we looked at the maintenance of angulation, they all maintained their correction to skeletal maturity, which is a little bit different from what is said in the literature. And I think it is perfectly possible to achieve correction and make it long-standing. there wasn't any statistically significant difference between the groups in this. When we looked at the results of forearm length, the centralization group, which had not been distracted, you can see had had the greatest impact on growth. The group that had been distracted and initially radialized, but then failed and had to have secondary centralization, affected growth to a lesser degree. And the group that had been distracted and then followed by radialization, which had succeeded, had the best increase in length. But statistically, there is actually no difference between those groups, although there is a hint that maybe if we follow up a much larger group, the differences between those groups may become more apparent. Of course, they may not. So centralization provides a reliable correction of the radial deviation, but radialization preserved growth and wrist motion best. And the patients were least satisfied when they went on to secondary centralization. Now, Alex looked at the rate of distraction, and we found that the group which had the quickest rate of distraction was the group in which radialization failed. And we thought that that is probably related to the fact that it implies that there's a weak combined radial muscle mass, which really can't act as a strong correcting internal force when transferred and just acts as a passive tenodesis. We also found that if you had a very short ulna at the beginning of treatment, which is most often associated with syndromic cases, and in particular TAR cases, the failure rate was in radialization was much higher. So how can we avoid failure with radialization? What we've adopted now is that we would centralize if distraction was very rapid and easy, or if you've got very floppy wrists without good muscle. We'd radialize if you've got a very good dorsoradial muscle mass with elastic distraction, which is more resistant to distraction. And we would, if we got a failure, we would move back to centralization early to get an early correction, because it's only going to get worse. And that was the result of our first 32 cases where we treated them by distraction and then got to skeletal maturity to assess them. And what we need to do now is to get Jill to take the next lot that have come to skeletal maturity and assess them. Thank you very much.
Thank you, Paul. That was wonderful. Really appreciate you doing this on your Sunday.
That's okay.
And I'll let Yang Guo take over, moderator.
Thank you so much, Dr. Smith. And before we go into the details of technique, which are, we can see a lot of questions in our chat room. Because you mentioned the different definition of centralization and radialization, it seems that different people have different understanding of that. Can you elaborate a bit more? Like, because you mentioned make a slot in the central part of the carcass. Can you elaborate more? What is centralization and what is radialization? And do a little bit of history, like who did it first and who did the radialization after that? Can you
well, I mean, Dieter Gramco came up with the whole concept of radialization. And interestingly, in his first paper, he pointed out that it was, that of course, this is a pre-distraction area. He pointed out that it was suitable for the less severe deformities. But he also, in his group of patients who he radialized, there were some patients in whom he cut a carpal slot. Now, to me, this makes it very difficult to compare series if you've got that. He also went across to opposite the second metacarpal when he was radializing. Now, so I think it's really important when you're trying to discuss this to have a very clear definition of what you're talking about. Some people, when they talk about centralization, talk about cutting a carpal slot in the proximal carpal row and making it opposite the second metacarpal. Some people talk about making that carpal slot opposite the third metacarpal. Some people talk about centralization as not having any tendon transfers undertaken. And so I think really we should be crystal clear when we're talking about these. And I think we should also, we should define whether or not the axis of the ulna goes opposite the second or third metacarpal, so that we can clearly differentiate between the different series. I mean, in our series, we just felt that the third metacarpal was the central axis of the hand, and that it seemed logical, therefore, to put the ulna opposite that. And the whole point of the presentation is just to say that actually you can get a full correction. You can maintain it to skeletal maturity. And I think it still has a role to play. Of course, I think if you look at the use of the vascularized second metatarsal that Wilke came up with, he gets fantastic wrist motion. And it's really impressive. But he has the problem, which he freely admits, of trying to balance the growth of a short bone against a long bone. And inevitably, when you get to past the adolescent growth spurt, that discrepancy becomes obvious.
It's also very difficult.
Yeah, very difficult. Yeah.
Very difficult procedure. So what do you think then? Do you think it's very easy to differentiate radialization and centralization as far as during the operation? Do you mean to in line with second metacarpal or third metacarpal? Is that big difference? I mean, in a real.
I doubt it makes any real difference, but it just appealed to me that the third metacarpal was the central axis of the hand. I think the crucial thing at the wrist operation is to make an assessment of the quality of that radial muscle mass. If it's a bulky muscle where the muscle looks of decent quality, then I can rely on that transfer as being dynamic. If it's a very atrophic looking muscle, then frankly, it's just a static tenodesis. And in those cases, I would veer more towards cutting a carpal slot rather than relying on that to try and help correct what is an unstable equilibrium when you stick it on the distal end of the ulna.
Great. Thank you so much for your explanation. And a question from chat room. What's your opinion about Wilke procedure?
Well, I think it's excellent. If we could find, maybe the vascularized fibular head will eventually, and of course, in China, you've done a lot of these, haven't you?
Some of the doctors published a paper about that. But yeah. I agree, it's very difficult to, because you know much more.
I think it's a great thing, and it gives you good movement. Aesthetically, it's maybe not quite as appealing, but if you're looking for functional movement, it's the way to go. If you're looking for aesthetics, perhaps not.
Yeah, Agree. Also, one question about, did you find any physical separation occurred during distraction?
I'm sorry, I missed that. Yeah.
Did you find any physical distraction or physical separation occurred?
No, I didn't see any. But the interesting thing is when we look back on that series, I don't think we distracted as much as we would do now. So perhaps, we were very, very cautious in the amount of distraction. And I suspect now we would distract much more than we did then. And maybe we would see it then, but I think because we were so cautious, we didn't see anything like that.
Okay. So can we move on to the next question then? When is the right time to fix the ulnar bowing?
Well, I don't think you need to fix it, because I think that the distraction, as you saw on that series of x-rays, you get remodeling. So I don't think the ulnar bowing actually needs to be treated. You just keep distracting until it corrects itself. I think the problem is the distal ulnar head, where the way the articular surface is facing may actually cause you problems that may necessitate a distal ulnar osteotomy at a later date to correct it.
So can I say that do you routinely do the osteotomy to the distal ulnar? So in every case, do you routinely do that? No.
No. In fact, we found that looking back over the cases, there were a small number of patients who had this sort of roof-shaped distal ulnar head, and they were the ones that caused the real problem.
Mm-hmm. So another question is, at what age do you start distraction youngest?
Well, I mean, we used a little mini Pennig fixator, and the age at which you start is the youngest age at which you can actually fit the distractor.
So let's say it's about 12 months or 10 months.
When we actually looked at the timing in our group, because it's a tertiary referral hospital for sick children, a lot of these kids had coincidental problems that took precedence over this. And so we didn't get at them as early as we wanted to. But I mean, if you could get to them at 6 months, I would have no objection to doing it then. But most of these cases, we didn't get at till about 36 months.
How about the older age? Like some of the patients have discrepancy of the both upper limb. So usually they want to change that the appearance. So do you do lengthening the ulna at older age, like 6 or 7 years old?
I haven't, no.
Okay. So any comment on politicization after wrist surgery? Do you do wrist surgery first, right? If the patient had some hyperplasia, and after wrist surgery, you would do politicization, or what's your approach?
Oh, I think that until you've got a stable wrist, you shouldn't do a policization. And policization in these cases is a completely different ball game from policization in a four-fingered hand. And I think it's in some of these cases, you do a policization on one side, and then you seriously look and you think, I'm not sure that the quality of result that you're going to get in a radial club hand merits doing it on the other side, So I think it's a completely different ballgame.
Okay.
I'm sorry, your last question about ulnar length at an older age, I misunderstood. And yeah, of course he can do ulnar lengthening at an older age. And in fact, we cooperated with our orthopedic colleagues so that, you know, if children came along much older and still had a discrepancy, of course they had ulnar lengthening. And I think, yeah, you just do it once.
How much can you usually lengthen? Because there are some contracture of the tendons, the soft tissues. Do you think how much can you lengthen the forearm?
Well, I think are you talking about this in adolescent, in the older child?
Yeah.
Well, my colleague at Great Ormond Street, who used to do a lot of this, was getting certainly 20% lengthening in the older child. But he was very careful about making sure that the relationship between the wrist and the distal ulna was maintained by fixing that and then distracting between that and a proximal fix.
Okay, great. Okay, I think it's already 8 o'clock. Shall we move to the next?
Yes, that's great. Yang, thank you so much. Paul, tremendous. You know, I think just as a comment, there's so much value to this kind of longitudinal data that we so rarely have. And the follow-up on these patients is just amazing. And as you said, you know right away if you have a bad result, but you don't know if you've had a good result. And because in the end, what we're really looking for anything that we do in pediatric hand is what are they like when they are skeletally mature and on to life, because that's our goal, right? So thank you for that really tremendous presentation. Yang, also, thank you for moderating.